AZCCC presents the Cancer Care Podcast, Arizona Center for Cancer Care. Comprehensive care with the highest quality of cancer treatment in Arizona. Joining us today is radiation oncologist Dr. Ashley Albert.
So before doing this podcast, we had you on video in our studios. You're like a pro. You're like a television pro.
Oh, well, thank you.
You know, if you didn't have that job saving lives, we could put you to work
thank you.
In video.
I think it comes from years and years of presentations and speaking in front of people with all of that training and everything. But thank you.
You've done a lot. Let's start with you as a person. You're not from Arizona originally.
No.
So tell us about where you're from.
Yeah, so I'm from Georgia, right outside of Atlanta, in a town called Marietta. So grew up there. Most of my family's still there in Georgia. Did my undergraduate at University of Georgia. Met my husband, Ben, there.
You're a bulldog?
I am a Georgia bulldog. That's right.
Where's the accent?
That's what everyone says. That's
Georgia.
what everyone says. So it comes out when I say things like y'all. That's the dead giveaway. But neither one of my parents is from the South, and I think being right outside of Atlanta, it's a melting pot. But the y'all, like I said, is the dead giveaway.
All right. So bulldogs.
Bulldogs.
Go Bulldogs.
Go Dogs. Yes,
so that's
sir.
where you went right after high school, and then what?
So I met my husband there, and we both were pre-med, then went to medical school at Mercer University, which is just south of Atlanta in a town called Macon.
Okay. Your husband, also a doctor.
He is.
What type of doctor is he?
He's an orthopedic surgeon, and he specializes in hip and knee replacements.
So everybody in your family is smart.
Oh, I don't know. We'll see. It's yet to be seen.
Do doctors typically hang out with doctors?
Well, I think once you kind of get started on that pathway, you meet other people doing the same thing. So we certainly stay in touch with our friends from medical school and everything. I personally don't have any doctors in my family, just something I kind of always wanted to do.
All right. And then you guys have kids?
We have kids, yes.
All
yes.
right. How many kids?
We have 3.
You're not busy, are you?
Not busy at all. Plenty of free time, all that kind of stuff.
So you and your husband have medical careers, and you have 3 young kids.
Mm-hmm.
And you've been out in Arizona now for about a year?
Yeah, almost a year.
All right. So you've been through the summer oven?
Yes.
You're used to it?
I don't know about used to it, but that was literally my first thought. This is an oven when we
Okay.
came here in July of last year.
How about Arizona Center for Cancer Care? You've been here a year and you've gotten to know everybody, and how's it going for you?
Oh, it's going great. I mean, it's really a great group, some very strong physicians across all the disciplines. So we're a multidisciplinary group. So that means we have medical oncologists, we have radiation oncologists, we have surgical oncologists. I mean, the whole gamut of specialties to serve each of our patients here. But it's a really just robust practice. I've really enjoyed it. I have a lot of great mentors there already. Have a lot of great leaders and people just showing the way of how it's done here. It's been great to be in this new city and meeting all the physicians in the community. It's been really great so far.
So, Dr. Albert, you've done so much, very accomplished. You've written, published pieces. You've been a public speaker. But in my mind, along with many people, including physicians, it starts with the patient. So let's start there and then work our way outward. Let's start with the patient and the mindset of a patient coming to see you.
I think that every patient that comes in, it becomes very routine to us as oncologists, but for every patient that comes in the door, there's just a lot of unknown. Maybe by the time they come to see me, they maybe have the diagnosis, but they don't know what the treatment's going to look like. They've heard things tossed around, chemotherapy, radiation, surgery. There's just a lot to process at that time. There's a lot of emotions. There's a lot of facts and dates and appointments and all of that.
So they know they have cancer, but they don't know what stage.
Exactly. Yeah. Yeah.
And then they're scared.
Absolutely. They're scared. Their families are scared. Their children, everybody.
And you're the one that has the initial conversation with them to really break down more specifics on the type of cancer they have and the stage.
It just depends on where they are in the process. A lot of times patients will present with a certain symptom. Maybe they go to their primary care doctor. Usually something is concerning, maybe a diagnostic imaging, CT scan, MRI will be done, maybe some lab work kind of helps the diagnosis be made. Then depending on what type of cancer it is, they're sent over to the medical oncologist or the radiation oncologist. How I try to approach it is I assume that they know little to nothing in a way that I can help them fill in any gaps. One of the hardest things is they're spoken to, like they understand everything. They know all these terms and this medical jargon, but I try to approach it and I tell each patient, I'm going to review things. You may have already heard this, but we're going to start from step one and go from beginning to end so I can make sure I know that they have all of the information.
You really take the human angle, because a patient coming in to see you, as we mentioned, they're scared. This is something brand new to them, although you deal with it every day as a physician. They don't understand the verbiage, and when they were originally diagnosed, they certainly didn't understand, probably at that point, what they were being told, because they're deer in the headlights. Their mind is, oh man, I have C, I have cancer.
Exactly.
That's all that's in their mind. So when they come to you, you break down that verbiage so they understand?
Exactly. A lot of times, just like you said, when somebody hears the word cancer, it doesn't matter if it's early stage. We have stage 0 cancers. It doesn't matter what stage it is. When somebody hears cancer, a lot of times they're done. Their brain stops listening. They stop taking in that information. So by the time they come see me, they may have had a couple of days or a couple of weeks to kind of slow down and process things. So that's kind of why I try to start from square one and just go from beginning to end so that I can make sure they understand all of it.
What are the questions patients typically have when it comes to radiation? Do they really understand what it is?
I think it depends. I personally didn't understand radiation before I was trained in it. And the reason I got into oncology was because my grandfather had lung cancer. So I was a pre-medical student and he was always trying to help me out. So he dragged me along to his oncologist, if you can believe it. You know, he's getting chemotherapy and he's like, here, take my granddaughter, let her shadow you. He had lung cancer, so he had to get daily radiation for 6 weeks. He had to get chemotherapy. I didn't understand what any of that was. I was a pre-medical student, but I thought he was going to go in this room and be blue beams coming down. I had no idea.
Did they catch it late? Was he late stage?
It was an advanced stage, stage 3. He eventually passed away from it. And so that was really instrumental for me and why I chose the field. But to answer your question, a lot of times people really don't know what radiation is. There's different types of radiation. So the first step when I'm seeing a patient is maybe to break down what stage cancer they have, how does radiation play a role in treating this cancer, and what's the radiation going to look like for them specifically.
Can we go back to your grandfather?
Mm-hmm.
Because that's interesting that became your why on becoming an oncologist. So you're pre-med at the University of Georgia.
Mm-hmm.
Your grandfather is diagnosed with stage 3 lung cancer, and you're close to your grandfather, and you go through the process with him. You go to the appointments with him.
I do. I was home for some of that time. My college was about an hour and a half away from where he lived, so I was home for part of the summer. He was a tough man, so he didn't want to admit any weakness, but he was driving through traffic to get to his appointments, and I would ask his oncologist, can he drive himself, very worried and concerned. Growing up, I was pretty scared of my grandfather. He was in the military, very intimidating kind of person, tough love.
It's that generation.
Exactly. And I remember asking his oncologist, why did you pick this field? And he told me, it brings out the best in people. And I'll never forget that because it was so true with my relationship with my grandfather. He was somebody that I was scared of. I didn't want to pick up the phone and call him because I thought he was going to yell at me. He was just a tough guy. So anyways, when he got that diagnosis of cancer, it brought us all closer. And I think a lot of oncologists have a similar experience where they had the family member go through cancer treatment. So being there with my grandfather, taking him to his chemotherapy appointments, taking him to his radiation appointments, seeing him go through that made us closer, and we started talking more regularly. And I really cherished that time because that diagnosis, like I said, it brought us closer. It gave us a relationship that we might not have otherwise had. He did the same thing with his other grandchildren, and it was really an amazing thing.
So when you see a tough Marine go through radiation and chemotherapy, that became your why with your grandfather.
It did.
What a tribute to him with all the people you've helped and continue to help.
Yeah, I guess so. I think he would be very proud.
I bet he would. So when your patients come in the back of your mind, is that with you? I remember going with my grandfather.
Absolutely.
And
yeah.
I want the cancer diagnosis explained to my patients the way that you wanted the diagnosis explained to your grandfather.
Absolutely. And there's a real fine, delicate balance of when patients ask, how long do I have? That's probably the most difficult question we as oncologists get.
How do you answer that?
I tell people, and everybody may have a different approach, I say, we don't know. The best I can do is maybe give you a range. Do you want to hear that range? And I preface that with, these are just statistics. These are the averages. Every patient's different. And I think that's important because that helps with planning. There's a big difference between being told you have maybe 5 years and being told you have 5 months. So I think, going back to the example of my grandfather, I think he kind of had that framework, had that timeline, if you will. And like I said, it's never exact, but I think that's very helpful. And I think it helped him get his life in order, helped him get his relationships to a better place. And I personally benefited from that. So that's kind of how I approach it. And of course, it's never easy. Some people don't want to know. Some people want to know to the date. And of course, we don't have that information. None of us know.
Is your first appointment typically with a family?
It just depends. Sometimes people come in by themselves. Fortunately, we're coming out of COVID and we can have more people come in. But I always love when patients bring family members because, like we talked about in the beginning, a lot of times patients are just overwhelmed. So to have that family member there to kind of take notes and help them remember things they might forget is always important.
You know, this is so interesting, and thanks for being so honest and sharing with us, because this really is something that you don't learn in med school. In med school, you learn medical. You learn how to be a great doctor like you are, but you don't really learn that human touch, right?
We do to some extent, and I'll give credit to some of my mentors. You know, there's another specialty of palliative care, and so those physicians are dealing with patients and treating patients, and they're very close to the end of life, and they're amazing in their work. So, you know, I had some mentors in that regard, and I guess I always gravitated towards that field because it's so closely related to the field of oncology. And so I learned from them in real life examples. If somebody's in the hospital sitting down on the bed, actually taking a seat next to the patient, you know, if they're comfortable, taking their hand, looking around the room and seeing who's there, who's got the box of tissues, whose dad is this, whose grandfather is this. So I think all of that certainly helps in a way. And I think it's just going back to my own experience and what I wanted for my grandfather at that time.
Is it difficult to manage patients' expectations ahead of time in terms of the visuals that they will see? Loss of hair, certain changes to the physical body. If they're not expecting that, that can be pretty rough. So do you tell them that ahead of time? I
do. And, you know, sometimes I wonder, maybe if I don't tell them, maybe it's a kind of a in their head thing. Maybe it won't be as bad. But I find that it's better to give them the information up front. And there's actually research to support that. So there was a study looking at patients with radiation side effects specifically, and about 30% said they actually wanted to know more. They felt like they weren't informed enough. Maybe the doctor kind of downplayed how bad it was going to be. And we as physicians tend to do that. We don't want to cause anyone pain when we're trying to treat them. Yeah. But a lot of times we do that. We maybe minimize it. So I think maybe we can approach and say, this can get bad, but I'm going to be here with you through it. This is what you could expect to be the worst. It may not get that bad. But certainly those things, like you mentioned, hair loss, you know, a lot of times with radiation, we may cause pain before we make it better. It just depends.
Appetite.
Exactly. Yeah. And that's where the family comes in. If the family can kind of be that objective voice when they're going through treatment and the patient says, I don't want to get up and go to treatment today, I don't feel good. And the family member can say, no, you got to go. And so I think that's where that all is important.
And there are times where there's happiness. Somebody comes in with an early diagnosis and you're like, I got you.
Oh, yeah.
We'll take care. Tell us about some of those cases.
Yeah, those are great. You know, obviously, nobody wants a diagnosis at all. But I think a lot of patients do have a good perspective. They say, it hasn't spread yet. It's early. My cure rate is, breast cancer early stage, cure rate's 99%. Very unlikely that this is something that's going to kill you eventually. We're going to cure you, and you're going to be done with this. It's going to be in the rearview mirror. So those are always gratifying. And a lot of times radiation in that role, for example, breast cancer, we're kind of an insurance policy. You already got the cancer taken out. We're just doing some radiation to make sure it doesn't come back.
You're getting the margins around it.
Exactly, yeah.
Can you immediately tell after radiation the results if you've gotten the margins?
Oh, so that's a good question. So the number one question we get during treatment is, how do we know it's working? Can you tell it's working? What's going on? And it just depends on the cancer. So some cancers we can't actually see. So breast cancer is an example. So the breast cancer has been taken out at the time of surgery most often. We're just giving the radiation, like I said, to decrease the chance that it comes back. We don't know if it worked until we get the post-treatment mammograms months later.
Mm-hmm. Talk about the different types of cancers that you treat. Is breast cancer the majority?
It's the majority. It's the number one cancer diagnosis in women. So by default, it's the main diagnosis that I treat. Mm-hmm.
Okay, and some of the others, like pancreatic, that's rough.
Yes.
Lung is rough.
Mm-hmm.
What are some of the other types of cancers, like breast cancer, that if they come to you early, you have a pretty good chance at really helping them.
Yeah, so some head and neck cancers, if it's an earlier stage and we're doing radiation and chemotherapy together, high rates of cure. Skin cancers, which are very prevalent in Arizona, they're more of a nuisance than anything, but we get those early. Sometimes it's too big to have any kind of surgery, so we'll give radiation. There's some gynecologic cancers. We catch it early and can treat with radiation at a certain point. So, yeah, that's why I like this field. There's just a good mix of everything.
So although we've worked together a little bit, I just wanted to cheat and learn a little bit more about you. And the first paragraph in your bio lost me because I think every letter in the alphabet was used at different types of treatments that you provide. So if I'm very humble, can I just bring these up and you explain to me what these are? IMRT, what is that?
Yeah, so you caught on that our field of radiation oncology really likes acronyms. So IMRT stands for Intensity Modulated Radiation Therapy. So basically, in simplistic terms, if you just think about we have a radiation beam coming from the machine, we used to treat with just a beam, basically. We could maybe block it off a little bit. The term intensity modulated means that during the radiation beam, that beam is being modulated in real time. So there's tiny little apertures moving constantly in and out of the beam. And what that does basically is kind of sculpt out the beam so that we can target the treatment a lot better. So we can kind of zone in on the areas that we want to treat and avoid the normal surrounding organs.
So the risk is much lower.
Exactly.
Think how far radiation has come, because when they first started applying radiation, the risk was much higher because they couldn't specify that target.
Yes. When radiation was first used in therapy, say 100 years ago, it was effective and they treated it all in one dose. And so as you can imagine, it treated the cancer, but the side effects were horrific. Through more research, we found, well, actually, if we divide that dose up to a little bit every day, we can treat the cancer, but spare the patients from some of the side effects. Fast forward to now, 2021, we're kind of circling back around where we say, actually, we can give high-dose treatments, but we're able to much better spare the surrounding tissues. So what we call our therapeutic window has increased. So we can give a higher dose of radiation, but it's much safer with the advances in technology.
Is that like is it space AOR?
That's one technique we can use for prostate cancer.
For protection of other areas, correct?
Correct, yes. That's a non-radiation technique, but it is something we use with prostate cancer.
So just think about being a young but accomplished physician. And I know you're involved with organizations that also do research for future treatments. Imagine where we're going to be in 10 years. Mm-hmm. It's unbelievable. Imagine where radiation has come, even since your time at Macon. Mm-hmm. So, and you get to apply that every day. Okay, IGRT.
So that stands for Image Guided Radiation Therapy. So we're actually able to do an image every day of the treatment site. So say for lung cancer, we do a small CT scan and we can see where the tumor is. We can see the normal organs. From a technical standpoint, we have to make sure that the patient is in the correct position every day. And so we use that IGRT to make adjustments to make sure that our target is spot on.
Does it move? I mean, I'm sorry for the rookie question.
No, it certainly can move. The patient setup can vary a little bit every day. So you would think you put the patient on the table in the exact same position.
Oh, I see. Mm-hmm. So you're not talking about the actual cancer. You're talking about the position of the patient?
Both.
Interesting.
Mm-hmm. It depends on the cancer, but for lung cancer, that's one that we can easily see on that image-guided imaging that we do every day.
What you do is so exact.
It is.
SBRT.
So that stands for stereotactic body radiation therapy. What that basically means is a very high dose per day, like I was mentioning earlier, and it's a much more focal radiation. This has been a really great advancement in our field. So say, for example, 15, 20 years ago, a stage 4 lung cancer that's in the lung, it's spread to maybe a couple sites in the bone. They were given some palliative chemotherapy and that was it. We have new data to show if we actually treat those sites aggressively with this focal treatment, we can actually prolong their survival in a stage 4 lung cancer. So it's pretty remarkable, the advancements that we've made. And so one of the reasons I love oncology is that there's different approaches. There's surgery, there's chemotherapy, there's immunotherapy, there's radiation. And so all of our disciplines are advancing every day, really, to help prolong patients' lives. And so, for example, SBRT is one of those ways that the field of radiation is doing that.
SRS.
So that is similar to SBRT. That one stands for stereotactic radiosurgery. In this case, it's usually
keep all this stuff. You're like just automatic.
I'm sure you have acronyms in your field with your podcast and production. But yes, the stereotactic radiosurgery, similar concept to SBRT, basically a focal radiation. This term is usually applied to metastases in the brain. So again, before we would treat the entire brain, and that was somewhat morbid, as you can imagine. We've, of course, come a long ways with that as well. But this SRS, or stereotactic radiosurgery, allows us to treat focal pinpoint lesions, treat the cancer, avoid the normal healthy brain.
All right. So brachytherapy, is that somewhat considered standard today?
It depends on the cancer. So brachytherapy is a really great treatment because it allows you to give a high dose treatment, and it's different from our other forms of radiation. So it's coming up from a radioactive source. So it gives off a high dose radiation, and the dose fall off is very steep. So give a high dose radiation and avoid the normal structures nearby. So a lot of times it's used for cancers, gynecologic cancer, cervical cancer, endometrial cancer. We also use it for breast cancer. So for example, early stage breast cancer, we can insert a balloon into the cavity. We hook that up to what's called an afterloader. It has an iridium-192 seed that goes into the balloon, delivers the radiation from the inside, treats just that area, very local. That radioactive seed comes out and the treatment's done.
Talk about identities that patients take on.
Absolutely. And this is a big one. There's this key word, or this kind of word that always pops up when you're talking about cancer, and it's this idea of being a survivor. And that almost can be kind of controversial in a way. Not everybody likes that term. So it was originally started in the 1980s. There was actually a coalition that kind of wanted to empower cancer patients. And so they came up with this term of survivor. And they actually intended it to include anyone that had a diagnosis of cancer and describe that time from the time they were diagnosed to the time that they maybe passed away from their cancer. Nowadays, not everybody likes it because, maybe there's this idea that if you aren't cured, then maybe you don't deserve that label of survivor. But it's kind of interesting because there's been some research to look at how do patients identify during treatment. And so I mentioned the survivor identity. On the flip side of that, there's this victim identity. And just as the name implies, it's not always a good identity to take on. And there's kind of more neutral identities, such as patient or person with cancer. Fortunately, the majority of patients do identify as a survivor. And the reason that's important is because that's been shown to be correlated with better psychological well-being during and after treatment. And I think all of those things are very important. And so you can't say just because you have a better outlook that your outcomes are necessarily going to be better. But I think it's important for the patient to thrive as best as they can during and after treatment.
The mental state of mind is such a big deal.
Absolutely.
For people battling cancer. Does some of that start with the physician?
I'd like to think so, or at least we can kind of help facilitate that. It isn't that you just put on a smile and we're going to cure your cancer, but how do you approach it? How do you come in every day for treatment? Maybe you're just in a rough spot right in the middle, right in the thick of it. But when you have that perspective, when you have some purpose behind it, you're going to get through the treatment easier, and you're going to have a positive impact on your physicians, on your treatment team. I mean, there's so many amazing patients that come through our doors that our team at our clinic is like, how do they do it? How do they get this horrible diagnosis with maybe a not so great prognosis given to them? But they come in with smiles. I mean, I have one patient, for example, I didn't cure him. I maybe helped with his pain a little bit, but he carves children's toys out of wood, and he carves them for my children. He's coming in with horrible pain from this cancer. And us as doctors aren't able to do much, unfortunately, but he's coming in and really touching us. So all that to say, making the most of something, nobody wants this diagnosis, nobody wants it in any way, but to be able to take it and turn it into something beautiful, really, it's quite remarkable.
Do you find that gives a lot of fulfillment to cancer patients? For example, when I see cancer patients ringing the bell after finishing treatment, to me, that's inspiring because I think no matter what I'm going through in my day, look at them. They're warriors. That has to make them feel good because they're enabling the inspiration of others.
Absolutely. I 100% agree with that. I mean, like I said, it's all about perspective and outlook. If we give you a cure, we get rid of this cancer, that's amazing. And that isn't always the case for everybody, unfortunately. But every step is a milestone. If you make it through your treatment and you're ringing that bell and you have a smile on your face, I mean, that is, I agree, so inspiring to other people.
So your patient that carves wooden toys, he has a goal. Let's talk about patients' goals, because you take the people approach.
Absolutely. So all of us as people have goals. I mean, initially our goals were to find food and shelter and survive. And as we have advanced as a human race, our goals have advanced, and goals give us purpose. So everyone has some set of goals. You throw a diagnosis of cancer in there, and that's obviously pretty disruptive. Maybe you had goals of traveling somewhere to see your grandkids. Maybe you were going to go hike some mountain or do something. This idea that cancer is disruptive to goals is really important, because there's been research to show that patients that are able to adapt and be flexible with those goals actually have better scores on well-being tests and whatnot. They are actually able to sleep better. They have a more positive outlook. So I think that idea of being flexible and having mental fortitude is so key to how you're going to be through your treatment, how you're going to interact with others. And I just think that's just so interesting, the fact that human mind can adapt and readjust in terms of what you want to accomplish with your life. And that actually has impact on your psychological well-being.
So let's switch to Dr. Albert as a family person. Kids. You have 3 kids. Does that make you a better doctor?
I think it makes me personally the best doctor I can be. I think having children helps me relate to other patients with children. You know, I have patients with breast cancer that have young children at home. They're going through chemotherapy, they're going through radiation, and they have little kids at home. Little kids are very physically exhausting. So for me to kind of understand what they're going through is, I think, helpful to be able to relate on that aspect.
You've been incredible today. Really, thank you for sharing so much. Have we missed anything? We've covered a lot.
We have covered
today.
a lot. Yeah, thank you for having me. This has been really enjoyable.
How about contact info for you? Probably the best way is just the website. If you go to AZCCC, all the doctors in our great organization are listed, but it's AZCCC.com. And of course, under radiation, you'll find Dr. Ashley Albert. What a tribute to your grandfather.
Yes, thank you. Thank you for letting me share.
Congratulations to your family, and thank you.
Thanks, Dave.
Thanks for listening, and please join us again for the Cancer Care Podcast, presented by Arizona Center for Cancer Care. For more information on the highest quality of cancer treatment in Arizona, please go to ArizonaCCC.com.